everyone to our webinar this evening, and I would like to also welcome Dr. Marshall for joining us, and he will be presenting during this webinar. My name is Jamie, and I am from the WA Primary Health Alliance, or WAFA, and I'm a primary health trainer here. And today we're going to be looking at, this is the second installment in our STI and BBV refresher series, interpreting STI results and initiating treatment. Before we get started, I just want to do a quick acknowledgement to country and acknowledge and pay respect to the traditional owners and elders of the land that we are meeting on today, recognizing their diversity and the significant importance of their cultural heritage, values, beliefs, and self-determination in contributing to the positive health and well-being of the whole community. Just a disclaimer for you guys as well that the webinar will be recorded tonight. So the good thing about that is it will be distributed, and you'll be able to refer to it later on in our resource library as well. We will be having a Q&A section at the end, so if you do have any questions during the webinar, please feel free to pop them in the chat, and we will have some time to answer questions at the end. I would like to introduce our speaker, Dr. Marshall, this evening. Welcome. Dr. Marshall is the sexual health and public health physician at Wooroloo PHU, and he's the former head of service at South Terrace Clinic. So we'd like to welcome you, Dr. Marshall, and I will pass on to you.
Thank you very much, Jamie Lee, and good evening to everyone who's actually with us tonight. So I've been asked to talk for 15 minutes just on results and treatment, and majority of this will be syphilis related because that's really where the tricky things happen. But I'll also be talking about chlamydia, gonorrhea, and mycoplasma genitalium at the end. So the first one I want to talk about was syphilis testing. I know you've had a webinar on testing recently, but just to remind you that the only way we can really find out about syphilis is through blood tests, and it's very simple. It's just request syphilis serology. That's all it has to go on the form, and every lab in WA has the same protocol where they start off doing a screening test, which is a treponemal specific test, usually an EIA, and if that's positive, they automatically go on and do all the confirmatory tests, which I'll talk about a bit later. But the other thing to also remind you is that we're seeing quite a lot of chancres now. And so if you see any mucosal ulcer, just swab it both for herpes and for syphilis on the same swab. You just have to take the one swab and just ask them to do syphilis and herpes on the one swab, and they'll give you that result. So just a little bit about that PCR result. It is fairly sensitive. It's about 70% sensitive. So we do get false negatives, sorry. But if it's positive, then we know that person has acute infectious syphilis and needs to be treated appropriately. The other results is a bit hard to see perhaps, but we start off with an EIA, and if that's positive, they always do a confirmatory test to make sure that that's a true positive, and I'll show you something about that a bit later. And then they also do what's called an RPR, a rapid plasma reagent test, which is it's not specific for syphilis, so it can be falsely positive in other conditions, but it's the only test we've got to see whether someone's acutely infected or whether they're responding to treatment. So it's important that we know about that test and put them together. I mean, the interpretation of syphilis serology is a lecture in itself, and I haven't got time to do that with any great detail today. But I thought I would just show you a few slides that might help you think about syphilis serology. And the main thing is, if you get a result and you don't know what to do with it, please just ask for advice. Everyone's very happy to do that. The lab will do that. The sexual health clinics at Royal Perth and Fremantle will do that, and public health units will do that for you. So please never hesitate if you're not uncertain about someone's serology and what you will do with that test. So I'm just showing you this test. So this is the EIA. This is the confirmatory test, the treponema pallidum hemagglutination test. And this is the RPR that I talked about, which is not syphilis specific. So you can see in primary syphilis, you can actually have all your blood tests negative. And so if you see something you think looks like like syphilis, please swab it because that's going to be the thing that's going to come up quickest and going to be positive first. So certainly do the serology, but if the serology is negative and the PCR is positive, you know this person does have syphilis, acute syphilis. By the time they get to secondary syphilis, all the tests are positive. Early latent, which is basically defined as 2 years after infection, all positive. And then with time, while these ones always remain positive, so once someone's had syphilis ever, their treponemal-specific antibody tests are always positive. And so that in itself doesn't tell you whether they've got new infection. It just tells you that at some stage in their life, they've been exposed to syphilis. And you can see that with time, the RPR tends to fall to negative. So that doesn't really help you with long-term patients. So if we go to the next, I've just got some possible scenarios just to look at, just to give you some example. And this is a very common scenario. You'll do serology on someone. They'll say, oh, the EAA is positive, the TPHA is positive, but the RPR is negative. So what does that mean? Well, all it means, all we can really say on the results on their own is that this person has had exposure to syphilis at some stage in their life. Is it old treated syphilis? Is it old untreated syphilis? And we just need some more information. So that's where you're going to have to ask the patient, have they ever had syphilis serology done before? Have they ever been treated before? Most people remember treatment for syphilis because it's a bit unpleasant with a large injection of penicillin. But without information, you can't interpret that serology on its own. All you know is that that person has at some stage in their life been exposed to syphilis, and you need to get some more information. Another possible scenario you might get is that EIA is positive and the TPHA is positive. So again, this means that they've been infected or exposed to syphilis. And in this case, the RPR is 16. So 16 is one of those watershed results, I suppose. Anything higher than 16 we know is acute and much more recent. Whereas the lower results we're not quite sure about. And they can be, again, is this old disease? Is it new infection and getting higher? Or are they already positive and are responding to treatment? And again, without you knowing any of that information, all of those scenarios are possible when you look at that sort of serology. So again, knowing someone's treatment history, knowing where someone's at in the pathway of treatment, then you need to know all of that, and then you can interpret this result. And the other one that's common is this one, which whereas you get an EIA that's positive and the TPHA is negative. The RPR is also negative. So in this case, is that a true positive? Now, we do get about 1 to 2% of people who will have a false positive EIA from some other interacting antigen. And so, again, on that basis, this could be very early infection. If you repeated that test in 2 to 3 weeks, that may well mature so that the EIA stays positive, the TPHA then becomes positive, and so will the RPR. But if you repeat that test in 2 to 3 weeks and the EIA is the only thing that stays positive, the total antibody is the only thing that's positive, then this is a false positive, and you can reassure the patient that they don't have syphilis. But you can't do that based on one test on its own. It is really important that we have a second test. So the treatment of syphilis is relatively simple. It's penicillin, but it needs to be long-acting penicillin. So syphilis is a very slow-growing organism, and so you need to have low levels of penicillin over many days so that it's enough to kill it off. You don't need a lot of penicillin on board. Treponemal levels of penicillin are very low. But you need to have consistency, and that's why we use this long-acting benzothine benzylpenicillin. So this is penicillin with a benzothine molecule added, so it stays in the circulation for a week to 10 days. So that's the recommended treatment. Luckily, there's been no recorded resistance to penicillin for syphilis anywhere in the world, and so it's one of the few organisms that we can still safely and reliably use penicillin for. So you get 2.4 million units or 1.8 grams is the dose. So if someone's got infectious syphilis, it's a single dose, although 2 injections. But if they've got non-infectious syphilis, which is more than 2 years old, then they need to have 3 doses, roughly a week apart. And I say roughly, we like it to be a week apart, but if it extends out to 10 days, that's also okay. So that's the recommendation. The tricky thing at the moment is that there's a bacillin shortage, that long-acting bacillin, and that's expected to last till about October. And there is an alternative. It's called extensiline. It's a French product. It's the same drug, but it's not pre-mixed like the other one is. So you don't have to keep it in the fridge, but it does need a diluent. And you can dilute it with either sterile water or lignocaine. But once you've reconstituted, don't keep it. Don't put it back in the fridge. It needs to be used once you've reconstituted on that patient that you're going to treat. Its other disadvantage, it has a larger volume, so it's a more painful injection. Although if you're using lignocaine for the diluent, that might obviate that to a certain extent. It's just like the bacillin. It's available in the PBS for a doctor's bag order or individual scripts. But I would really try and encourage you not to give patients scripts for them to go to the pharmacy. Often the pharmacies don't have it. And I think it's much better if you can get your practice manager to order this for you as a doctor's bag order, so it's always available to you to use if you need to treat the patient. Your pharmacy might be reluctant to get this, but if you encourage them to say it's a TGA 19A drug, just say that to them. They'll know what that means, and then they can order it for you. And the other thing, as well as penicillin allergy, it's a soy-containing product. So if someone has true soy allergy, they wouldn't be able to take this. And just finally, if you're having difficulties in accessing these drugs, just contact your public health unit, and we'll do our best to help supply you. But as I say, I think having it in the surgery as part of a doctor's bag order, you don't have to then rely on individual prescriptions. You also need to remind the patient they can get this thing called a Jarisch-Herxheimer reaction. So it's a response to the dead bugs. So the penicillin kills the spirochetes, the body reacts to that, and you get a flu-like illness. Usually within 2 to 24 hours after you treat them, they get a fever, malaise, rigors, a bit like I say, having the flu. Just reassure them that this is part of the process. They take Panadol, they rest, they take fluids, just like they would for any other thing, and it goes away after 24 hours. And the only other time when it's really important is if you're treating someone in pregnancy, and that JH reaction, as we call it, can put someone into early labor. So it's important if they're later in their second trimester or in the third trimester, that they are monitored to make sure that they don't go into labor if you need to treat them. But for most GPs, that's an uncommon thing that you have to do, is treat syphilis in pregnancy. So the only other thing, we've discussed all these things, but really just telling the patient that they're infectious for 7 days after treatment. Ask about contacts, because if they don't get the contacts treated, they're going to get reinfected. So it's really important to think about that process. Doesn't mean you have to do all the contact tracing, but the patient needs to know that they need to be thinking about their contacts. But the most important thing that we would really ask you to do is to repeat the serology on the day of treatment, because we need to know what the starting RPR is. It's the only thing we've got to monitor response to treatment. And if we're relying on an RPR that's a week or 10 or 2 weeks old, we may not know what the true starting RPR is, and we can't monitor it over time. So please, on the day that you treat someone, please repeat that serology. And of course, for women of childbearing age, please make sure that they're not pregnant. So I just wanted to move on now and talk a little bit about chlamydia. I think, a lot of us have said, azithromycin, that's all you need to use. Well, the problem now is that mycoplasma genitalium is becoming much more common. And if we use azithromycin for someone who's got, say, in a man who's got dysuria and urethritis, and we don't know what the cause is, if we give him azithromycin, we're going to induce resistance to mycoplasma genitalium. So the recommendation is to use doxycycline as the treatment, the preferred treatment for chlamydia, 100 milligrams BD for 7 days. For women with PID, then we need to use 2 weeks of that therapy. The only time I think azithromycin is useful for chlamydia is in a man who is asymptomatic. You do a screen and the result comes back positive, and you know it, therefore you know it's chlamydia, then azithromycin would be a reasonable treatment in that man. Mycoplasma genitalium, I won't spend a lot of time on, just to know that doxycycline, you need to have at least 2 drugs to treat mycoplasma genitalium. We always start off with doxycycline, and then we add azithromycin if it's not resistant, or we add moxifloxacin if it is resistant to azithromycin. And they're the 2 mainstays of treatment from a general practitioner perspective. If they fail that therapy, then I think we need to, I seem to have lost my camera. Anyway, if they fail that therapy, then we need to make sure that you refer those patients on, and there's other things that we can use. But they're the standard treatments in a general practice setting, is doxy and azithro, or doxy and moxy. For gonorrhea, just to remind you that we've only really got 1 drug that routinely works for gonorrhea, and that's ceftriaxone, 500 milligrams IMI, and please dilute it with 1% lignocaine to give it intramuscularly. It's a very painful injection if you don't use the lignocaine. And then we also recommend giving azithromycin 1 gram orally to help prevent resistance. Given we've only got 1 drug that routinely works, we want to make sure that we're not losing that as an option. So the 2 drugs together mean that resistance is less common. If you've got true penicillin allergy, I mean, cephalosporins and penicillin, everyone worries about that, but in reality, very few people are truly allergic to cephalosporins if they also have a penicillin allergy. There are things you can use. Ciprofloxacin is useful, but only if you know the resistance. And I know Path West will give you whether it's resistant to ciprofloxacin or not. Azithromycin has been used, but the tolerance is, people often vomit if they have 2 grams. And I'm just throwing in gentamicin just for completeness, but it's not something I dare say you will use. If you're having problems treating someone for gonorrhea, again, seek advice at the sexual health clinics. For those working in the Kimberley, then you will know about ZAP packs, and I won't put any more information about that. So if you do need more information, as I say, please ring and ask people. Everyone's always very happy to help people out. If you put in Silver Book into your Google search, then the WA Health Silver Book will come up. It is in the process of being updated. It's going to be much more closely aligned to the Australian STI management guidelines, which are published by ASHM, the Australasian Society of HIV Medicine. So either of those are very useful. This one's very GP oriented, and will give you very good advice on treatment. But as I say, never hesitate to call someone. I think I've used up my time, so I will stop there and ask now if there's any questions. I noticed there was one question came up in the from about false positives. So the false positives, the main thing with false positives are if someone's got an intercurrent illness, autoimmune diseases can do this, and so you can't do much about that. Where we do find a lot of false positives is people who inject drugs. I think because they have a lot of other foreign proteins in their blood, they can get false positives with these tests. And Aboriginal people, again, will have relatively higher rates of false positives. Again, thought maybe it's things like parasites and other infections that can do that. So there's nothing specific that you can do to stop the false positives, but just be aware that in those cohorts that false positives are more common.
Lovely. Well, thank you for that, Dr. Marshall. That was the only question we had, and I think it's because your presentation was so informative. So thank you for that. And thank you for all who have attended this evening. We thank you for joining us. And I know it's late and it's cold, but if you can, I've also just put a QR code on the screen. If you have any feedback about the webinar this evening, or you have any interest in future topics you would like to see from us, then do let us know via that link, and we hope to see you guys again soon.
Bye.
Bye bye.